views on sickle cell anemia. Yes, indeed a very important topic for all us Africans as well as Indians, because considering its prevalence, it must be uh, discussed in detail. Yeah. Is my screen visible?
Yes, Dr. Sukriti, it's visible. Your face is not fully visible. If you can tilt the computer screen a little bit.
Sorry.
Your face is not fully visible.
Is it now?
No, no. I mean, we can only see
Just
till the nose level.
okay. Just a minute.
Screen is not visible. You are visible. Yeah. Now it's better.
Now it's fine. Yeah. Okay.
And screen, you haven't shared screen yet.
Yeah. Share. So is it visible now?
Yes, Dr. Sukriti. You are visible. Screen is not.
My screen is not visible.
No.
Just a minute. Yeah. Okay.
Hello.
So is it visible now?
Yes, it's visible.
Yeah,
I
you
think
can.
Dr. Innocent wants to say something. Yes, Dr. Innocent, you can ask.
No. You
Any
guys are
questions?
audible.
Okay, Dr. Sukriti, please go ahead.
Yeah. Can I start? Yeah.
Yes, please.
Yeah. Thanks once again to the Jivo Health, Mr. Varun, for giving me this platform for discussion of sickle cell anemia, and indeed a very important topic for all of us Indians, transplanters, and all my friends sitting there in Africa who encounter this situation very frequently. So, yes, why is this African-Indian collaboration very important in case of sickle cell anemia? That's very important to understand before I begin this topic. There is a very high commonality of burden of sickle cell disease in both the African countries, especially the sub-Saharan African countries and the Indian nation. And we both belong to the third world countries, so we have our own limitations of resources where we have to manage all these chronically affected individuals with sickle cell. So we need to discuss together, lay down management protocols, which should include early screening, prevention of the disease, and to come up for a definite cure of the disease, which is usually in the form of stem cell transplant. A timely referral based on the patient's symptomatology and a proper communication, treatment planning based on logistic challenges which we all face in day-to-day lives is very important. So as we just talked about, considering the epidemiology of sickle cell disease, us Indians, the sub-Saharan African countries, including the Republic of Congo and the rest of the Africa, we give rise to nearly 500,000 newborns of sickle cell each year, despite so much awareness, and 80% does belong to sub-Saharan Africa. So yes, most of us have been reading about this in the MBBS or basic study days of our medical schools, where a sickle cell, we just see the hemoglobin shape is altered, they become crescent, sickle shaped. And this is basically because of the abnormality of hemoglobin. So these red cells are very crucial for our day-to-day lives because these rounded erythrocytes, which are flowing through our vessels, they have very important role in terms of oxygenation of the body, carrying oxygen from one part to the other, and they should have a decent lifespan of 90 to 120 days. And this maintaining of organ functions through oxygenation with the help of proper erythropoiesis, hemoglobination is very important for our body. So this hemoglobin, which is contained in the red cells, has a very organized structures, two alpha chains, two beta chains. So this protein is very well organized with the chain of polypeptides properly folded. Now, once there is any kind of mutation or any genetic change happening in these protein formation, so in the case of sickle cell anemia, the genetic change happens in the chromosome 11 HBB gene, where a single amino acid shift from glutamine to valine takes place. And this leads to an abnormal folding of protein. And because of this, there is abnormal structured hemoglobin, because of which there is a kind of an abnormal coagulation, and hence the structure of the entire red cell gets damaged. So apart from sickle cell, which is HBS, there are other kinds of variations in the hemoglobin structures which can happen because of other genetic changes. So these are different type of hemoglobin we come across: HbA, A2F, S, C, E. So this I'll talk about later in the diagnostics. So HBS is what we are talking about today predominantly. And since we are talking about the genetics, so we should remember the typical Mendelian inheritance, which we again studied in medical schools very early in life, where both the parents who are otherwise normal looking healthy parents, they carry one small gene. Basically, they're autosomal recessive. So they're carrying one small sickle cell gene and one normal A gene. So because of this, the individuals that are born out of these parents, so one is normal, two of them have sickle cell minor, that is again trait, that is one gene, and these are again not affected. But out of the four, one individual, that is a 25% chance of inheritance of both the S genes, leading to a sickle cell disease can happen. Now, apart from AS phenotype that we have talked about, there can be AS, and in the other, there can be something else, that is AE, AC, AD, which I mentioned in the earlier slides about all these abnormalities. So even because of these variations, the fourth candidate that we see, that is SS, this can be either SC or SE. But again, these are also behaving like sickle cell, but relatively a milder or moderate form. So how do these crescent shaped, sickle cell shaped hemoglobin, they behave abnormally in the blood flow, and they cause all the problems, all the symptoms in our body. So basically, while flowing, in the second picture, we can see, as compared to the first picture above, the sickle cell, they clog the vessels in which they are flowing. They don't flow smoothly because of their shape. And because of this clogging, the flow is compromised, and hence the oxygenation is compromised. Because of which the red cell's lifespan will be shorter as compared to a normal 90 to 120 days. It's just 20 days, and they break down fast. The body compensates by producing excessive hemoglobin, but again, the hemoglobin formed is faulty in these individuals. So symptom wise, these patients have fatigue because of chronic anemia. And because of this clogging, even small blood vessels, they specifically get clogged very easily. And hence they can cause severe symptoms of pains in the bones, joints, and even in the chest, tummy pain. All this can be a part and parcel of sickle cell sickling crisis. And the pain intensity varies from individual to individual, though we have same phenotype of HBSS, but despite that, the intensity, frequency, and the duration of crisis can be quite variable. Some have acute, long-last acute pain for a short while. Some even have a chronic pain, which is quite debilitating over time. And apart from this pain, other kind of vaso-occlusive crisis which we face is the small vessels of the hand. They get compromised because of blood flow, and there appears to be swelling because of the localized inflammation, infarcts in the bone marrow. There can be priapism in young male adults. And even because of sickling crisis, we can see some individuals, the spleen vasculature gets compromised, because of which the spleen gets shrunken over time. And spleen is a very important organ for providing humoral immunity. And once the splenic function is compromised, spleen gets shrunken. The frequency of infections get significantly increased, especially the encapsulated organisms like streptococcal pneumonia and meningitis. These are more common in sicklers. And even the delayed growth is important symptom. So overall, the complications that we see is again related to the similar compromised blood flow. When the compromised blood flow happens with the brain, there can be compromise of the brain function, abnormal movements, loss of consciousness, weakness, and if not looked after properly, it can be fatal. Yes, any questions, please? Yes, Dr. Dinal, do we have a question from you? Okay, sorry. I hope the session remains interactive, because as I discussed in the very initial phase, it's a very common problem shared between both our third world countries. So please be interactive. Feel free to engage yourself. I'll be happy to interrupt and answer you. The presentations in our countries may vary, but definitely we can lay a common treatment plan in order to help all the different individuals. So moving further, brain is one vital organ, as I talked about, can be compromised. Other than that, chest syndrome is frequently seen in these individuals, manifesting as chest pain, fever, breathing difficulty, again because of clogging of blood vessels of the lungs, which can be precipitated by a lung infection. And pulmonary hypertension because of, again, the vasculature being compromised over time. So any other end organ damage like kidneys, heart function can be compromised. Usually all this is seen in adulthood, and that's why we prefer early picking up, early screening of children. That is very important. So again, the eyes, because of the blocking of retinal blood vessels, continuous hemolysis, that is breakdown of these sickle cell red cells, which have a lesser lifespan, can lead to a raised bilirubin levels, gallstones, leg ulcers, which is seen in other hemolytic anemias as well. And sometimes because of acute stress like high altitude or febrile illness, we get hyperhemolytic crisis, where there is a sudden drop in hemoglobin because of excess hemolysis, and this hemolyzed cells can compromise uh, the kidneys, the blood flow in the kidneys, and there can be a picture of interstitial nephritis, acute kidney injury. Beyond that, in the setting of even some atypical viral infection like parvovirus infection, there can be appearance of aplastic crisis, because in sickle cell anemia, very commonly the bone marrow stops functioning in the presence of parvoviral infection. Parvovirus can itself cause a myelosuppression. So in a sickle cell, the risk is even more increased.
Dr. Sukriti, can I interrupt you? So there's a question
Absolutely.
from Dr. Justin. Do you want to take it now, or do you want to take it at the end of the presentation?
Absolutely. Please go ahead.
Okay. So there's a question from Dr. Justin James. He asks, can adults present with dactylisis, and why it's more common only in children?
Yeah, dactylitis is basically when the small blood vessels of the hands get compromised, and that's why there is swelling of the fingers of the hands. So it's usually more commonly seen in children, because in children the development of the collaterals is not so well seen in children, whereas in adults there is a more the vessels are not so small that they don't clog so easily, and the formation of collaterals in these, even with these small vessels, is more common. So that's why dactylitis is more common in children.
Okay, okay, doctor, we can continue with the rest of.
Yeah, okay. So considering all these complications and all these ill effects, chronic morbidity that we see with sicklers, the importance of diagnosis, early screening is definitely very important. So the most important test is the hemoglobin electrophoresis. Yeah, there are other screening tests, sodium metabisulfite like test, which can cause sickling of red cells, but normally we don't prefer that at this point of time, because we have hemoglobin electrophoresis very easily available even in our third world country setting nowadays. So all those screening tests like sodium metabisulfite is not very much preferred nowadays, because they can give false results.
Dr.
So
Sukriti, we have a further question from Dr. Abraham from
yes,
Ethiopia.
please.
He asks, in terms of treatment, how gene therapy is done, possible for all patients, while
Yeah, I am coming to the treatment part later. Gene
okay,
therapy is very much
okay,
evolving.
okay, you will cover it. Okay, Dr.
Yes,
Abraham,
yes, yes.
this will be covered later in the talk. Okay.
Yeah. Right now we are at the diagnosis. So yeah, so the HB electrophoresis is an easily available definitive test, and the results are also available in a day's time. And many of the countries carry a routine newborn screening program. So basically, there is a gel electrophoresis made of cellulose acetate, or there can be some alkaline buffers also which are running this kind of electrophoresis. And we see different kind of hemoglobins that we talked about: HbA, F, C, D, E, and hence we can pick up whether it's a pure sickler, a normal child, a sickle cell carrier, or some kind of a combination of sickle cell, thalassemia, or other kind of hemoglobinopathy. This can be picked up, and the genetic basis can be explained to the family. Once we pick up a sickler in a family, all the other family members must be screened, especially the siblings and even the parents. The upcoming generation, we should do the genetic counseling beforehand. So yes, prevention is always the key if we look for the eradication of a disease. So genetic counseling, yes, picking up the disease at the earliest. This can be done with the help of what is called as amniocentesis, where we take the amniotic fluid around 16 weeks of pregnancy in an expecting mother. This is done in a case of strong family history, or when a previously recognized sickler is present, and the mother and the father both have been screened and found to be HBS carrier. In that case, we can get to the genetics of the forthcoming child beforehand. So withdrawing this amniotic fluid, this can be taken up for special genetic testing for sickle cell genetic changes, the HBB gene that I just mentioned about. And this takes nearly around 10 to 14 days. We can't do HB electrophoresis with this fluid. This has to be utilized for a genetic change examination. Another similar method is a chorionic villus sampling, which is done from the placenta through either the cervical or with the abdominal approach. And this can be done even earlier in the pregnancy, that is from 9 to 11 weeks. Again, it's a kind of genetic test we do from that tissue, and the duration it takes is nearly 2 weeks.
Dr. Sukriti, sorry for
Yes,
interrupting. There is a further question from Dr.
yes,
Stephen Kope. He's from Cameroon. So, for
yes.
positive diagnosis, the level of hemoglobin S, is it the same in all countries?
So yes, usually the sicklers have the sickle cell, the ones who are carrying both the genes. they have a level of HbS more than 60%. Less than 60%, the manifestation is quite minimal. And less than 50%, it is usually seen in sickle cell trait or a sickle cell combination hemoglobinopathy, which is like HbSC or SE. But beyond 60% is definitely a sickle cell major, which is HbSS. And definitely the severity of symptoms are increased with an increase in the proportion of HbS, but not always can they be exactly clinically correlated. I mean, there can be no exact mathematical correlation of the percentage of HbS and the manifestations. But yes, there is a tendency that more the HbS, the more the symptoms.
Thanks, Dr. Sukriti. Let us continue.
Yes. Okay, thank you. So in India, we have a national sickle cell elimination program where we target eradication by 2047, thanks to our government, where we plan for a regular HbA electrophoresis, newborn screening, family screening programs, encouragement of bone marrow transplant in eligible candidates, and even the evolving genetic therapies are underway in India. So coming to the treatment, the initial treatment should be, once we have a sickle cell patient with us, the initial treatment involves avoiding crisis and relieving symptoms and their complication in all these children. So it has to be a very calculative approach in terms of the supportive care and the definitive approach that we are just coming to talk about. In the supportive care, whenever we have a sickler, a known sickler with us, routine visits to the hospital is important. For children, it should be, even if they don't have any symptoms, it should be a 2 to 3 months visit to any general practitioner or a pediatrician. And they should be started on penicillin prophylaxis. Vaccinations should be stressed upon. And additional, they should be taking flu shots and pneumococcal vaccine, all the sicklers. And the penicillin prophylaxis is recommended up to 5 years of age. And in high risk cases, it can be continued even later.
Dr. Sukriti, are you ready to take one more question? It's from
Yes,
Dr.
please tell me.
Sante from Nigeria. His question is, he's thanking you for the presentation. And the question is, can you throw more light on the pathogenesis of stroke in SCD children?
Yeah, so this diagram would give you a partial answer, because there is something called as a transcranial Doppler. Although it is not so frequently carried out in India, but it is suggested to be carried out in all the sicklers, where we use ultrasonic waves to see the flow velocity in the cerebral vasculature, and hence based on the abnormal flow of the vessels, we can pick up the risk of stroke earlier in these patients. So definitely, as I talked about the regular visits to the practitioner, this based on the previous TCD, at 2 years of age, we should do the first transcranial Doppler. And based, if there is any abnormality, we can take it up further a bit earlier, that is 2 to 3 months. And if there is no abnormality at all, the cerebral blood flow pattern is found to be good enough, this can be screening can vary from 6 months to 1 year in the sicklers.
Dr. Sukriti, we have two more questions. A
Yes.
follow-up question from Dr. Justin. So when do we do sickling test in other way, is specifying? Can we have negative sickling test but positive electrophoresis, and in which conditions?
A negative screening test and a positive sickling test by a negative screening and a positive HB electrophoresis is less common. A more common false positive is seen when there is a dehydration and febrile illness, where even a I mean, we see even a negative a sickle cell trait being shown sickle cell positive by screening test. So that condition is more common by this sodium metabisulfite screening test. Whereas, but yes, false positives, false negatives are also seen with the screening test. Why it is seen, we don't have a clear answer, but yes, false negatives can be seen. So
There's,
definitely HB electrophoresis should be done when there is a family history. HB electrophoresis is always preferred.
so there's a question from Dr. Mercy. Again, thanking you, and she got here a little late, so maybe you covered it. But doctor, the question is, what types of stroke are they most likely to suffer from, and how can we prevent its occurrence?
Yeah, so I was just talking about it. Common strokes that we see is the MCA territory, which is the same as the adults. We see the posterior and the middle cerebral territory being affected more commonly, but sometimes even the anterior can be affected. But the posterior and the middle is more commonly affected. And I was just talking about it that the regular transcranial Doppler above 2 years of age is an important method to pick up the individuals at a risk of stroke early. And we can give medications for prevention accordingly, though it may not be 100%, but that's what we can do. And regular follow-up and monitoring is important.
Okay, Dr. Sukriti, we can no more questions yet. We can move ahead.
Yes. So yes, for all the vaso-occlusive pain crisis, sickling crisis, adequate hydration must be remembered as a must for all these children. They should take their fluid intake should be a little more, around 10 to 20% more than what is actually required for that particular age. So normally we say less than 2 years, it should be 4 ml per kg, and in above 2 years, it should be around 3 ml per kg of fluid intake over the day. In adults, it can be 2 to 2.5 ml per kg. So the
Ma'am,
next
one more
is
question. One more
yes.
question. It's from, okay, two more questions. So it's from Dr. Brian from Zambia. So he's asking, I mean, your comment on the use of hydroxyurea in pregnancy and what are the alternative options?
Yeah, even in the all those women who are active sicklers and they have ongoing pregnancy. Normally, we if especially if they don't have a frequent pain crisis, and most of the women who have been doing well till this age of childbearing age, and they have been able to uh, get pregnant. So we expect their pain crisis, their sickling crisis, or vaso-occlusive crisis to be lesser. And in these individuals, we can consider to hold on hydroxycarbamide for a while. When the Because it is definitely not a good option for the fetal development. And the same time, we advise a better hydration and uh, avoiding any other stressful conditions. That's the best we can advise. And apart from that, definitely the folic acid supplements is something that must continue.
Dr.
So
Sukriti,
that is,
two more
yes.
questions. One from Dr. Innocent. What are ethical curative therapy dilemmas with SCD transmission from childhood to adulthood?
Sorry, please come again.
What are ethical curative therapies and dilemmas with the SCD transition from childhood to adulthood? If the question is not clear, I mean, we can
So
request the.
I think we are talking about the definitive therapies, which is the bone marrow transplant, the stem cell transplant, and the upcoming the gene therapy. I think we are talking about that
Yeah, that you
from
will cover
childhood to
separately.
Yes, yes, yes. So I'll be
Okay.
coming to that. Right now, we are talking about the supportive care, which again, painkillers for the pain crisis, the regular blood transfusions, which can be done when the hemoglobin is low. So giving a blood from a normal individual to a sickler, that will reduce the proportion of the sickle cell, that is the HbS percentage, and it will increase the normal blood percentage in the blood that is present. So definitely the risks which is associated with a high level of HbS, that is stroke and other painful vaso-occlusive crisis, that will be significantly reduced. If the hemoglobin level is high, that is above 10 gram percent, then we can think of red cell transfusion. In that case, we think of something called as a red cell exchange, where we take out an equal proportion of blood from the patient, and at the same time, we are giving uh, red cells from a healthy individual to the patient. So we are taking out and we are giving also, so that the hemoglobin doesn't increase, yet we have healthy red cells in the body. Again, this will help in reducing the vaso-occlusive crisis.
Dr.
Yes.
Sukriti, there is another question related to pregnancy only from Dr.
Yes.
Justin. So question is, what is the best mode of delivery for a sickle cell patient, considering sickle cell pain and labor pain?
Yes, so we always prefer cesarean sections, uh, a timely planned cesarean section. Usually, this is done in India at 36 to 37 weeks of gestation. An elective cesarean is planned, and these women are monitored a little more, much more frequently in the third trimester. Twice a month visits is preferred to the gynecologists, and any abnormal blood flow is monitored. They are given the respiratory maturation, beclomethasone and dexamethasone earlier, so that the lung maturity happens in the forthcoming baby earlier, and the delivery can happen earlier whenever needed. If the blood flow, we see if the blood flow gets compromised at any point of time, we plan it earlier. Usually we plan an elective cesarean, as I mentioned, so that the stress involved with the labor pains and all is minimized.
That's all questions for now, Dr. Sukriti. We can move ahead.
Okay. So yes, pharmacological agents, hydroxyurea, we just spoke about. It is one of the most commonly used agent for all the sicklers, because it increases the HbF percentage. Other agents have developed and have been tried, which I'll just mention quickly. And hydroxyurea, by increasing the fetal hemoglobin and increasing the nitric oxide in the blood vessels, it helps to dilate the blood vessels so that the red cells can flow smoothly. And by increasing the fetal hemoglobin percentage, again, the sickling crisis gets significantly reduced. So it's quite a helpful drug theoretically, but practically how much it helps in the long term, that really varies individual to individual. Some nitric oxide supplementation has been studied in the at an experimental level, and we see that L-arginine depletion and impairment of NO, nitric oxide synthesis. This compromises the vascular dilatation. So there are certain drugs on the way of development, like stenostrothiol, so that the nitric oxide levels are better maintained, although they haven't come into market. Other drugs which had come into market commonly, that I just shown the flowchart, voxelotor was commonly was very well talked about drug in 2023, when it 2019, when it got its first FDA approval, an accelerated FDA approval, because it inhibits the polymerization of this uh, the sickled hemoglobin molecules which happens. So once it inhibits the polymerization, the red cell damage and the vaso-occlusion gets significantly reduced. But again, it was more theoretical. Even again, another drug was crizanlizumab, which is an intravenous drug which inhibits the p-selectins, and the p-selectins will inhibition will not cause this red cell aggregation and vaso-occlusion to happen. So again, Both these drugs were found to be very useful. They both got accelerated approval by the FDA. However, on practical use, they had a lot of safety issues, and now most of them have been withdrawn at a global level. So, most important that we would like to talk about is the definite theoretical therapeutic options in sicklers now. So, yes, the most common, most talked about in the world is bone marrow transplant. When there are significant symptoms, and even on hydroxyurea, red cell exchange, the symptoms have been significant. They are compromising the organ functions and causing a debilitated lifestyle. This is something which should come into play. And beautifully, it was observed way back in the 20th century itself, when an individual for which bone marrow transplant was performed for acute leukemia, he got cured of sickle cell entirely once the transplant was performed. So since then, this has been talked about as the only potential cure. And we see in this diagram the bone marrow cells, where bone marrow is the tissue in the bones from where all the red cells, white cells, platelets are formed. So this tissue is entirely replaced with donor stem cells, the healthy stem cells. So this kind of a recycling that happens, now the blood which will be formed in the body would be a healthy red cells, healthy platelets and white cells. So this is used for many kinds of white cells and red cell disorders, sickle cell being one common disease. So one important requirement is a HLA match donor, which is usually found in the families. A full match is usually a sibling. So we have been talking about HLA in our, again, early medical school days, where there are class 1, class 2 loci, and 6 loci are most important on chromosome 6. And matching of these between the donor and the patient is important. The best match is a full 10 by 10 match, or a 12 by 12 match amongst all these alleles that we can see. And this is one example of a report where only one mismatch is present in the last allele, 5 and 14. So this is a very good match. Now, bone marrow transplant, although it's a non-surgical procedure, there is no cutting involved. It is entirely a medical procedure. The name transplant does not indicate it has to be surgery. It's a medical procedure. Any episode of stroke is an absolute indication. Acute chest syndromes, especially 2 episodes, transfusion dependence, painful crisis requiring hospital visits more than thrice in a year, and the regular screening of any cardiomyopathy, tricuspid valve regurgitation. In that case, definite treatment would be a bone marrow transplant. Apart from that, when we see a strong family history and we have a full match donor available, even with less symptoms, we try doing the procedure at an earlier age because the success rate is very high. So yes, the patient should be preferably a younger age with good preserved end organ functions and a suitable donor. Again, all these are the prerequisites for a successful bone marrow transplant. Then definitely financial implications must be understood by the entire team, the family. This is important.
Dr.
So
Sukriti, we have a
yes,
question on, you talked about financial implication. We have a
yes,
question on that, at least at your center at Artemis, how much,
yes,
okay, there are two questions. First from
yes,
Dr. Steven, was the age limit. You talked about careful selection in early 20s, but we ourselves from Jivo, we have helped patients like late 20s get successful bone marrow transplant here in India. Patient is doing well. And the question is, what are the cost implications? I know it's different for full match, it's different from for half match,
yes,
different for if from directory there is a donor available, which rarely happens. And
yes, yes, yes.
what is the upper age limit for transplantation?
Yeah, so for a full match donor, definitely the stay in the hospital, the less toxic, the medication regime, and the stay in the hospital, the medications, the supportive care that we utilize get significantly reduced. And in that case, we can go in for a 24,000 to 25,000 of USD. But again, that is very much dependent on the patient's age as well. A younger patient, say 2, 3, 4 years, the cost is even lesser. But an older patient, say an adult, uh, beyond 15 years, where the body weight is just equivalent to an adult, the cost would go up to this level. Usually, maximum age that we have pursued is 26 years. Again, that was a full match at 26 years that we have pursued. So, but the course was a little turbulent, to be very frank, and that is what is said. So, definitely, again, the
Okay,
overall, the organ functions, everything is important.
Sukriti, what is the cost implication in case of half match transplant?
Yes. I'll say for a half match transplant or for an unrelated donor transplant from a registry where we find a full match, usually the cost is the same, because in the registry cost is significantly high, but the complications get significantly reduced. All the donor charges get reduced because of the registry help. So for a half match or a outside donor transplant, the cost would be around 33 to 34,000 USD.
Okay. And doctor, like when we are talking about the above age, like your experience is oldest patient is 26, but
Yes.
I have seen like somebody who was, it was a half match transplant done by Dr. Dharma, uh, uh, and the patient was 28 years old, and it was a half match, and
Okay.
the transplant was successful. So, like, can it be done for patients who are nearing 30? Or maybe that was a lucky case.
Yes, even see, honestly, we should not depend on one person's data and one individual case, to be very frank. So I would rather look at the bigger picture. How many, I mean, all over Delhi NCR, how many have done patients above 25 or in this segment of 25 to 30 years? How many transplants in sickle cells have been done, and what was the profile? uh, all this we should all sit down and take a look at it. If suppose we are doing suppose in a total number of 20 transplants being done from 25 to 30 years of age, if 2 or 3 have survived well, or even 4 have survived well, 4 5 have survived well for that matter, I would be skeptical about doing it. But again, patient selection, how was it planned? The profile of those 3 4 individuals out of the 20 who have survived against those 15 16 who have not survived, that would again be an important question for all of us, because there's a lot of bias in all these data. So when I talk about my own patients, I know about each patient profile very diligently. So I look at it, I'll carry forward the experience
So
accordingly.
just for clarity,
Yes,
like, and larger data set, uh,
yes,
beyond 25, the complication and risks are higher. As you said,
definitely,
like less than 16, the
definitely,
best age group,
definitely.
and 16 to 25 still viable, and beyond
Yes.
25, it becomes risks are higher and it
So
becomes very
above
individual.
25, we'll do a very detailed planning like a DTPA scan, the TMS scan for the heart, and all those should be done before taking up any patient for the transplant. A very well preserved kidney function, heart function, and individual who's otherwise quite debilitated and the family is entirely willing. Definitely, age is not always the a fixed barrier.
Okay. And
That's how it is.
there's another question from Dr. Chucks. He's a pediatrician in Nigeria. So at what
Yes.
age do we commence hydroxyurea?
So, as per books, it said we commence it as early as we detect it. So normally, we can commence it as young as 2 months of age, as early as we detect it.
Okay, okay, Dr. Sukriti, we can continue with your talk.
Yes. So the process of transplant, on one hand, we have a donor from whom we just give a few stem cell booster shots, which is the filgrastim, the granulocyte colony stimulating factors. We give those shots for 4 days, and on the fifth day, our donor is ready for collection of all the good stem cells from the body. And this is entirely done from the patient's blood. We don't have to poke in the bone marrow of the donor. So from the patient's blood, we do this collection, and then it is kept in the blood bank for preservation. On the other hand, we have a yes, yes, Dr. Innocent. On the other hand, we have a patient who undergoes a chemotherapy. With this high dose chemotherapy, his own capacity of making the stem cells forming the bone marrow is entirely destroyed. And once this happens, we then give the donor stem cells that we have collected and kept in the bank to the patient. So this infusion in the patient, which is again done from a normal vein, just like any blood transfusion, this is what we call as a bone marrow transplant. Till here, the entire process looks very easy, and it is most of the time very well taken up, very well tolerated. A crucial step is the chemotherapy. The chemotherapy that we give to the patient. That is one important crucial step, because the intensity of chemotherapy will indicate how much is the chance of relapse further, and it will also indicate the non-relapse mortality. Higher intensity, the mortality, the risk of organ damage and the risk of infection because of high intensity is more, but the successfulness of a transplant would be more when we are more intense. But again, we are all third world countries. We should not take a US data. We have to be calculative in terms of preventing complications, yet having a good success. So these engraftment is the most important step. The steps that we talked about till here, till infusion, that's considered quite simple. There is no complication most of the times. But once the engraftment has to happen, where the donor stem cells have to find their way into the patient's bone marrow and start producing healthy blood cells, healthy red cells, healthy white cells, platelets, which is indicated by a rise in neutrophil count, most importantly. So this happens in around 2 weeks of time, and it can go up to 3 weeks also, depending on the regimen intensity, as I just talked about. So engraftment is a very crucial step. All us transplanters are scared till a patient gets engrafted. So there are complications associated. Most important we talk about is infections. Then the second most common we have is the graft versus host disease, where the donor cells can attack the patient's body, and there can be some complications related to it. And then there can be a situation of failure. There can be a poor graft function of the donor cells and failure of the transplant, which can cause the disease to come back, and even damage to the organs because of the toxic regime can happen. So all this becomes more with the half match or unrelated donor. And as I mentioned, the full match sibling donor is always the best. So infections, depending on the timing of transplant, we must be knowing what infections we should keep in mind. In the early phase, the bacterial infections are most common. Sometimes the fungal infections, but atypical bacterial infections are much more common. And in the later days of engraftment, we have atypical bacterial and atypical viral infections being very common. And once there is an onset of graft versus host disease, beyond 100 days, then we have encapsulated organisms role coming into play. So we give prophylactic antibiotics, antifungals, antiviral to all our patients timely and accordingly. And we monitor any signs of this infection also. Second most common, as I talked about, is the graft versus host disease. This can be either acute or chronic. So the donor T cells, basically, they can cause a damage to the organs of the patient, because the donor T cells which we are infusing during the stem cell transplant, they recognize the patient cells as foreign. And because of this, they attack the patient cells and they cause damage. In acute GVH, we have involvement of the skin, liver, and the GI tract most commonly. And in the chronic involvement, we have the skin, eyes, oral cavity, the liver, lung, and the musculoskeletal system. So there is a little difference in the pathophysiology. So this is more the chronic one is more with the related to the fibrosis of the underlying organs, whereas in acute cases there is because of the T cell related damage, it is more kind of more of an acute hypersensitivity kind of manifestations which happen, and the grading is different. GVHD can be a separate topic entirely to discuss upon. This is the basic that I'll talk about. We give medications to prevent GVHD time to time and monitor their any symptoms of GVH. So for all my patients for whom I need my friends to follow up in their own countries and in this remote living settings. So this important platform, the post BMT monitoring is very important, very crucial. As I talked about all the complications, the successfulness of a transplant entirely depends on the follow up and timely monitoring of any signs of GVH, any organ damage, any infection, timely picking up and managing the same when the patient has gone back to their home country and is in contact with the physician, pediatrician, general practitioner. That becomes very crucial for us. We have in the last 3 years follow up, we have so many patients who are in communication with us through WhatsApp. They inform a symptom and we ask them to seek a medical help accordingly. And so communication with my doctor friends at their hometown would be a very important step, and we all need to get sensitized to it. So in the early period, initial months, they need every twice in a month follow up, and later monthly visits till at least 1 year is important. So I can be followed up on Facebook, Insta, emails, WhatsApp, LinkedIn. This is all the platforms that I'm available. And most common chats is WhatsApp chats with my patients.
And we have also tagged Dr. Sukriti's LinkedIn profile for easy, so that you can find her
Thank
easily.
you. Thank you so much. So
On
now
the
we have a Jivo partner. I am very sure the communication through them would be very smooth. And I hope there should be the lack of monitoring should not lead to any kind of mishap from any end. So
uh,
I'm sure all our partners would be involved at the right time.
Dr. Sukriti, my one
Yes,
more request, and I mean, we have faced this question. So
yes,
a couple of years back, that CRISPR gene
yes,
editing therapy, it got FDA approval in US.
yes, yes.
And so when I speak to doctors and practitioners, they are of mixed views. Some are very hopeful about the impact gene editing, although it's very cost prohibitive right now, about the impact it can. And some doctors are of the view vis-a-vis bone marrow transplant, that bone marrow transplant has 30, 40 years of demonstrated history in its curative,
Absolutely,
and
absolutely.
gene editing therapies are still new. We still don't have enough data.
Absolutely. I'll be coming
What
to
are
it,
your
that
views?
I'll coming to all the consensus as one slide. Just I'm sharing my experience of bone marrow transplant.
Okay, okay.
So I'm sorry, it was a last minute slide. Today morning I got the data of my hospital where I could consolidate at once. So I remember most of the patient, but consolidating together at one slide, I've done it today itself, taking data from my hospital registers and all. So we have equal number of full match and half match transplants that we have done. And around 80% of full match have survived and 60% of half match have survived well. And the reasons of non-survival have been all the major infections in the early period, acute GVH, chronic GVH in their home country, relapse disease. So out of these, what I have noticed is that chronic GVH and relapse disease is something which could be very well prevented with the proper medications being followed up timely in their home country. So this is where our partners, all my doctor friends really come into play. And next time, I think I'm very sure last 1 year was much better than the previous 2 years. So we'll be able to do even better. Last 1 year, even the haplo result was 80%, but before that, it was not so good. I'll be frank in every aspect. Showing any false data of 90 to 95% success is not my cup of tea. This entire data is very clear and non-fake. This can be taken out from our hospital anytime. So yes, now we are talking about the interesting genetic editing approaches. So yes, the approval was first received in 2023 by the FDA, which was in 12 years and older, not the younger individuals. It was in the older individuals. So there are two methods, gene editing and gene addition. So the process is initially the same. Basically, we don't need a donor. It's the patient's own stem cells which are collected. The patient is mobilized again with the filgrastim for 4 days. The stem cells are collected. Now these stem cells are modified in a laboratory with the help of either viral vector or with the help of CRISPR genetic Cas9 genetic modification method. So either of these two methods is used, and this method takes around 6 months as of now for the editing to take place. Once the editing and the genetic modified cells are ready for us, we give again some chemotherapy to the patient to destroy his stem cells. And then we give this modified cells to the patient so that now again this genetically modified cells are formed and healthy red cells are again formed in the patient's body. So since the cells that we are giving back is the patient's own cells, their recovery is expected to be earlier. They are not donor cells, which where the recovery is relatively delayed to more than 2 weeks and all. So yes, this is the gene editing therapy, which is the CRISPR-9 Cas9 enzyme-based therapy, where the beta globin genetic change is modified using this technique after collection of the stem cells, and the damage which is happening at the DNA damage which is happening in the parent cells, that gets modified. Whereas in gene addition, the previously abnormal gene is there, but we have gene addition based on some vector addition, viral vector, and ultimately these cells will still express a modified appropriate hemoglobin gene and a functionally normal hemoglobin. So these were approved, and presently they are well available in other countries like US, European countries, Switzerland, even Saudi Arabia, Bahrain. And Indian research institutes, CSIR, IGIB, and AIMS is working on it. And even our center, Artemis, is giving our own, our patients are taking, we are taking some autologous cells from our patients also and giving it to CSR, IGIB. We have a collaboration with them. So even we are involved with the gene therapy. Once the gene therapy is approved in India, our hospital would be in frontline for its availability, because we have collaboration with the CSIR IGIB.
Dr. Sukriti, how far away, how in India, how far are we from gene therapy to be available? Like how
Quite
many?
difficult to gauge the government answers to it, but what they're claiming is next few years, 2 to 3 years, 2 years maybe,
Yes.
we'll get the approval and for public.
So
Yes.
currently, bone marrow transplant is the only
Absolutely,
therapy.
absolutely. And we don't know what cost it will come forth.
Okay. So
So
Dr.
yes,
I
yes,
mean, for our doctor partners who are attending,
yes,
whenever a new therapy comes, so when I have spoken to doctor community, I mean, their opinion is divided. Some look at
yes.
the gene therapy because of, as you said, patient's own cells who know graft versus host risks and complications. So they see
Absolutely. The complications we expect is relatively much less. The infections, the graft versus host disease, they'll be quite minimized.
So if we remove
So
cost financial part, I mean, if we don't consider variable just from
absolutely,
the medical
absolutely.
perspective, but some are of the view that bone marrow transplant as a curative therapy is proven for decades. The patients who have
Yes,
gone
yes,
through it,
yes,
they have held a very healthy lifespan. So
yes.
that's why I mean it is. So what are your views on bone marrow transplant versus gene therapy?
So okay, my thought extend to some other diseases. I'm a little extrapolating it. I don't know. I People really don't talk about it, but I often extrapolate it to other diseases like certain metabolic immunodeficiency diseases, in which I'm from a basically pediatric background. As a pediatrician, I have encountered certain common genetic metabolic problems in our patients, where like there is some uh, because of some metabolic problems, they have brain complications, they have liver lung complications. And in these diseases, there are two kind of therapies. One is the enzyme replacement therapy, and one is the bone marrow transplant. Worldwide, if you see enzyme replacement therapy, the availability and the cost is quite discernible, and that's the reason that's being followed less commonly. But definitely, wherever it is being followed, even in India, certain individuals who do get enzyme replacement therapy, they do beautifully, but the cost is very prohibitive. The side effects are quite minimal. The cost is the only prohibitive factor as compared to a BMT. And BMT is definitely a little toxic. We have protocols and medications and every monitoring, every aspect, which has significantly minimized the toxicity of bone marrow transplant. But I'll still feel, as a pediatrician, looking at those enzyme replacement therapies and other metabolic genetic disorders, I feel gene therapy should be the forthcoming best therapy
Now,
once we cut down the cost.
Dr. Sukriti also want to address the
Yes,
elephant in the room, bone marrow transplant, a beautiful curative therapy, toxicity,
yes,
I mean, accepting the toxicity, etc. But
yes,
uh, there is also risk of death.
yes,
So let's say
definitely.
when a family is planning, let's say for example, the academic, what the academic research says that full match, early age, 80% success, so that out of 180 patients will treatment will be successful, but 20 will succumb to death. So, I mean, if you can educate, because a lot of it, while if they have a sickle cell patient and if they are recommending treatment in India, they will face this question from the
Absolutely.
patient or parents. And I mean, if you can shed more light over it, how you
So,
consider it as
talking from
a-
a very okay, talking from a very practical point of view, in a medical field, whenever we talk about any treatment, what we tell the families at the very first place is, whatever treatment decision you take, you must go till the end. We must complete it. So it has to be an informed decision. If cost is not a barrier at all, I will always recommend gene therapy once it is a little better studied and it comes up in my own country, in my own practice a little. I will definitely recommend gene therapy if the person is sure the finances will not be a barrier. But if in case the finances may be a barrier, then I'll definitely say that you must take a very calculative decision. Tomorrow, the gene therapy, even the gene therapy takes a lot of time. It takes 6 months for the process to happen. And in this 6 months, how much the urgency of the procedure is again is a very important question for us. If the patient is recently developing severe crisis, stroke like episode has happened, they can't even wait for 6 to 8 months for the gene therapy. In that case, a bone marrow transplant should be given a chance. But in other cases where finances is not a problem at all, and we can wait for this much time, then yes, go for a gene therapy once it is a little more widely available.
Okay, but ma'am, the moot
That's
question is like in all the developing countries like India and Africa, finances
Mhm.
are issue for 99% of the population.
If the finances are an issue, I will still prefer an allogenic BMT. In the experienced hands, the allogenic BMT has given us wondrous results. Yes, definitely there is a that 10%, 15% lag will be there. But if we just sit on that 10, 15%, and by any chance we are not even able to complete that gene therapy process, because I would not recommend anyone to just, lose out on everything for a sickle cell child. Just don't lose out on everything. Medical field, I do not recommend families to just lose out on all the resources for the disease sake. I'll say just be a little calculative. Even the allogenic bone marrow transplant is doing wonders and it's a mature data. So trust the doctor that you are doing with and go for it. If the finances is even a little barrier, then go for a transplant.
Okay. Any
But
more
again,
questions?
donor availability is another issue that has to be taken care of.
Okay, but ma'am, aren't parents, if they are not sicklers themselves, aren't they biological parents definitely a half match?
Yes, that's what they are, half match.
So,
Not all the parents are fit enough for a donation.
okay, and
Not all
how?
the parents.
Ma'am,
Especially, I tell you, in African settings, what we have very commonly come across is parents may be HIV positive,
yeah.
so they are not fit for transplant.
Okay, so
That is one common setting. Yes.
excluding, let's say, HIV, okay, its prevalence was used to be most in Africa, now reducing thanks of a lot of measures. So let's say parent does not have HIV or other limiting factors, which prevent
Yes.
the donor. Other thing, they are not sicklers themselves, like they
Yeah,
self.
yeah, yeah. If they are non-sicklers and no organ compromisation and no particular comorbidity like HIV, yes,
They
parents
would
as half match donors are good.
they would definitely be half match, right? So
Yes, yes, yes.
there is always theoretical donor availability within the family, right? And how about siblings, ma'am? Siblings being, what are the chances of real siblings, like both parents same? What are the chances of them being a match?
A full match sibling chance is usually 25%. That's what we say, full match sibling. And a half match sibling is better than a parent, in fact. A haplo sibling match is better than a parent because the acceptability of cells from a sibling is lesser. The antibodies with the sibling cells is lesser as compared to the parents.
Okay,
So the acceptability of a sibling half match is much better as compared to even parents. But sometimes the siblings can be no match at all.
okay.
So
So,
in that case, they can't be donors.
when there is
Yes.
a, like in any family, I mean, removing obvious sick people like with organ damage or HIV or being sicklers themselves, there is a
Yes.
realistically good chance of at least finding a half match within the family and close blood relatives, right? Inexplicably.
Other close blood relatives are usually not even half match. You talk about aunts and cousins and uncles, they are not half match usually. We don't find them to be half match.
Okay. So, like within the, I mean, so theoretically, like compared to, let's say, a kidney transplant donor availability or a liver transplant donor availability, at least a half match donor availability in bone marrow transplant is realistic, right? Unless there is a, as you mentioned, issue with HIV status or parent sickle cell disease status itself.
Okay, since it's a non-surgical procedure and there is like no complication at all for the donor, the we are able to convince the donor more in bone marrow transplant for a donation in a half match case in a immediate family. To be very frank, uh, kidney transplant is finding a donor in a case of kidney transplant is much more feasible, but it's the mindset of the families which has to be taken care of. That's very I mean kind of prohibiting factor for us. Even
Yeah.
in the kidney donation there is hardly any risk. 1 in 1,000 or maybe 1 in 10,000 risk is there, I don't deny, but at such a minimal risk, I mean, we should always favor a kidney transplant from any blood relative. In a kidney transplant, we can go for a first cousin, a second cousin, anything we can go for. So the donor availability, just not if the mindset is not prohibiting, it is much more available in kidney transplants.
Dr. Sukriti, there is one request. Although we upload the recording on the we record the session and upload it on YouTube and share the link
Yes, yes.
with all the doctor
Share.
partners for. But but this is a long session, like more than 1 hour. Few doctors have requested if you can share the presentation.
Absolutely,
Not
not a
French,
problem.
if you can share with us, we will translate the French version and share with you. Those.
Yeah, absolutely. I'll share it. No problem.
Okay,
I'll share
thank
it.
you. If I'm waiting for any other follow-up question. A lot of questions were asked during the talk itself. Thanks for making it so interactive. If you have
Yes, sir.
any,
Please go ahead.
yeah, if you have any follow-up questions, you can ask now, or you can ask in your in your Jivo work group. We will share it with Dr. Sukriti.
Yeah, but I
Your
can talk about it later also.
Okay.
And I hope my audience has enjoyed it, and I'm looking forward for a better collaboration and the monitoring and follow up of patient. Making it even better is my aim with this kind of a collaboration and working out on the logistics. Yes, absolutely. When a
Uh,
doctor is involved, I think it's much more easier for us.
thank you, Dr. Sukriti. I mean, with your permission, I think we have exceeded the time also by almost 20 minutes. So, with your
Sorry.
permission, we can conclude the session for today. We can
Okay.
organize
Thank,
a repeat session in after in a couple of months.
thank you. You have done well.
So yeah,
Sorry.
Dr. Sunday is saying thanking you, and
Okay. Thank you
there,
so much. It
there
was indeed my pleasure.
there are many compliments in the chat also from different doctors.
Okay.
Thank.
Okay. Thank you so much.
And if you have, my request to you is if you have any sickle cell patient where you think, uh, opinion from Dr. Sukriti or her team, or you feel that you want to evaluate if they may be a good candidate. Because what I understood from this session is that theoretically BMT is a curative, but a lot of evaluation should be done whether it is a fit
Yes.
therapy or not. So if you have any patient you want to discuss, you can share the information with us on the Jivo work group. After this session concludes, you will get an email also. You can share it there, and we can do it two way. Either we can document the patient case file, we can help you document the patient case file and share it with Dr. Sukriti. Or if you have few of you have many patients, we can organize a sort of an online OPD session with Dr. Sukriti where we share reports beforehand with her. We agree on a time with her and you, You bring your patient to your clinic, and Dr. Sukriti can join from Zoom.
Online,
And
yes,
you
we can do it.
you can do
We've
physical.
been doing it.
Yeah. Well, we have been
Yes.
doing it with Artemis, with many of our doctor partners, ma'am. So, but for this
Yes.
also, so we'll don't worry, we'll find a way for this in
Yes.
for making this collaboration so that the Indian specialist and you, who is with the patient, you can work together. Thank you again for your time. Uh,
Thank you.
and
It was indeed a pleasure, and I hope every one of you found it useful.
thank you. Thank you.
Thank you.